Good morning. It is really wonderful to see everyone here today, and the stars of the show for my talk are you all, presented with the data that you have submitted to the Benchmarking Alliance, and frankly, the work that you have done back at home, making your patients better off, making your staff better off, and stabilizing what is sometimes a chaotic situation in managing your emergency departments. The Emergency Department Benchmarking Alliance takes data from now 850 hospitals, and those of you who just received your 2012 survey, we will have over 1,000 hospitals submitting data that provide us with the feedback that we need to tell you you're doing a great job, or areas that need to be honed on, and some project areas. Some of those projects Sherry has brought together today and are reflected in the posters on the side of the room. And many of you are doing projects at home that allow your staff to improve delivery of care and again allow your staff to be proud of what they do taking care of patients in the ED. The survey is really one part of a, I'm not advancing. Could you help me, please? Rick, could you advance, please? There we go. We have a big job in the emergency department. Even though we're not building it any bigger, our patients are still moving into the emergency department in growing numbers. Those numbers really increased November, December, January in most of your emergency departments when we saw our latest flu outbreak. This one extending across all of the age classes, but primarily affecting the seniors. And for those of you who didn't read the headlines from the CDC last week, we had a vaccine failure for the senior members of the population last year for reasons that the CDC still doesn't understand. So these are our numbers. The numbers began to be collected in earnest by the CDC in 1992. You see trend lines that would point you in a direction that says growth in emergency department volumes continue. And you'll see 2010 took a bump down from 2009. I will explain that in a minute. The CDC's report is called the National Hospital Ambulatory Medical Care Survey, or NHAMSIS. The CDC had a staff group that developed this survey, published it about 3 years after the calendar year and that the data was collected. And unfortunately, they lost the funding for this survey. 2007 was the last year that they wrote an analysis on it, and now only data tables are available. The data tables published last month were for the year 2010. I have summarized those and incorporated them into the talk here. And for those of you who submit data for the Benchmarking Alliance, you'll get an analysis of this report back shortly. In addition, as you know, CMS has taken a step to begin to collect data. CMS's dedication about 10 years ago was to develop materials that would allow their customers, the CMS beneficiaries across the country, to make better decisions about where to go for health care. They insisted that they needed emergency department markers, and they asked some of us to be involved in developing the markers that would be used for the emergency department. They developed the pneumonia measures, the acute MI measures, and other things that you've been living with now for the last 6 or 8 years. This year, they're reporting a new number. They wanted a time parameter to be able to report on, to represent the efficiency of the emergency department in managing patients. That efficiency marker, originally they were going to use average length of stay. Average length of stay in the emergency department as the marker for all 5,000 EDs in this country. Would that be fair? Anybody who runs a place under 20,000 would say, that's a fair number. Anybody who runs an emergency department that sees over 60,000 would say that's a very unfair number. And managing that many people per day makes it very difficult for you to turn them quickly. Anyone who sees an admission rate over 20% of the patients that they see would say that's a very unfair number compared to an ED that admits 1 or 2 or 5%, because naturally those numbers would look much worse. And then, frankly, urban emergency departments have a much more difficult time than rural emergency departments being able to process people. So in and of itself, even using average rather than median would be difficult for our staffs to be able to produce improvements. And since many of you are faced with the issue of holding mental health patients in your emergency departments for very long periods of time, whether they're going to be admitted in your hospital or admitted to another hospital, if you use arithmetic means, that can produce some very, very long disproportionate numbers. Median takes that out, and therefore for years, based on the recommendation of some of the EDBA leaders, we have used medians as the appropriate time interval. CMS decided then to use the decision to admit, and of course the decision to admit reflects boarding time in your emergency department, and all of you recognize that boarding time is your enemy when it comes to being able to process people efficiently through the front door. Therefore, an opportunity to focus on boarding times in your ED, and when you sit with administration, with the CEO, COO, CFO, CNO, is a really relevant issue and a really relevant marker for you to be able to focus on to reduce those boarding times. As we started the Benchmarking Alliance, we had no definitions. Frankly, the original members of the Benchmarking Alliance didn't even agree on what an emergency department patient was. And everybody used a definition that included, well, we don't include patients that walk away. We do include everybody who signs in on evening or weekend hours that's going to OB because they're an unscheduled visit, so we include none of it was defined equally. So Sherry Welsh led an effort in 2006 for us to host our first summit, and the entire objective of the summit was to produce definitions, uniform definitions across our industry. And then from those definitions can come performance measures and things that you can actually compare with your peers. And then if you want to compare with your peers, we didn't want 20,000 volume EDs being compared to 100,000 volume EDs, pediatric EDs compared to adult EDs. And so then cohorts were developed out of the 2006 work. That work needed to be updated again, and Sherry hosted a meeting in Salt Lake City in 2010. And out of that came two papers published in the July issues of Annals of Emergency Medicine and Academic Emergency Medicine 2011. And with those three papers, you have the definitions for most of the parameters important in managing your emergency department. It is likely that in the next 12 months, we will host another summit, getting together all of the representative factors again that relate to emergency medicine performance and operation, bringing CMS, Joint Commission, AHA, ENA, ACEP, et cetera, into the room. In 2010, AHRQ was part of the formula and assisted us in developing performance measures that would allow them to do research. And so bringing all those disciplines together in one room allows us on one day in one room to put together the markers that are really relevant to you. All right, NAHAMSIS update from 2010. Volume was down in 2010 relative to 2009 for a very, very explainable reason. 2009 was our year with H1N1, and your EDs typically set new volume marks in 2009. Fortunately, H1N1 was not a fatal disease. It disproportionately affected younger people, and there were many days both in the spring, a little lull in the summer, and then the fall, where we had volume bumps in all of our emergency departments. That was not matched with an admission bump because fortunately, again, most of those people got to be seen in the ED and go home. In 2010, acuity was up relative to 2009, should be no surprise. And however we measure acuity, and last month's Annals has an article by Steve Pitts, who was one of my partners at Emory, and Steve tried to go through and reflect that acuity bump was not about upgrading the charge masters. It was about actually growing acuity amongst the patients being seen in the emergency department. And the important demographic trend, which continues unabated in our country, thank goodness, which is we're getting older. We're getting older. We don't have people dying prematurely, and therefore we see an aging population. We're matching most of the world in terms of aging our population. Everyone is chasing Japan, which statistically has the oldest population on the globe. And this is a reflection of better health. And so we are following the trends of preventing premature death, preventing people from dying too early of avoidable causes, and watching our population age, and learning to deal both with the healthcare side of that, which is an elder population. You have to do things differently and manage them differently, and in some cases design your emergency department differently. And number two, look at the costs of providing healthcare. As we get older, we get more diseases, it gets expensive to take care of ourselves. Steve's paper reflects that in terms of acuity and aging. And until we change the demographics, it is unlikely we will change the finances significantly in healthcare. All right, your job is to utilize and assist the CDC in getting their data. For all of you who are asked to be members of the CDC data survey, there are 500 emergency departments in the country that typically get asked. And just so you know, the CDC's NAHAMSIS data comes from a sampling of about 45,000 charts from about 400 EDs, because usually about 20% of you turn the CDC down when they ask to come and use your ED as a sampling site. The sampling methodology, just so you know, this study is the one that then gets reviewed by other people, and they produce the statistics on how many fireworks injuries we have and how many ED visits come from children falling out of carts at the shopping center, et cetera. That's what this database is about. And it's an elegant sampling methodology, but does not look at emergency department performance. That's the Emergency Department Benchmarking Alliance's job. But I want you to know we collaborate hand in hand with the CDC to make sure that we have data that makes sense to the public, makes sense to the regulators and legislators. And since we're operating 2 years ahead of them, we tell them what their data is going to show when they go to collect it. All right? The next thing we have to do is at some point we are going to use our data on a much more live basis. And we made run at this, and the CDC couldn't get it funded. But at some point they're going to string together our emergency departments and be looking live at what our volumes are, what our acuities are, and what our local mixes are of certain diseases. And then we are going to produce a live version of weather forecasting for the healthcare system, because your 5,000 EDs are a great sampling point for healthcare in your community and what diseases are affecting people at certain periods of time. And just like weather forecasts, we will have the healthcare forecast for the day, and it will say today in San Antonio that they're seeing snake bites, and since the blizzard is blowing through the Midwest, they're going to see ice and snow-related injuries, and the flu is winding down, and we can watch that live. So just so you know what the future version of Benchmarking Alliance and CDC activities are to use the 5,000 sampling points of emergency departments across the country to produce live national, regional, and local forecasts. The Benchmarking Alliance has to produce the data that you need to help you do your job. By doing that, we also don't put ACEP and ENA in untenable positions. We find places to put this out, and Sherry, again, is our leader in terms of finding ways to publish the information that we collect. It's our opportunity to pull together the decision makers and to do the summits the way that we have done. Very important is that we develop data that allows you to counteract street legend material. And everybody knew that ambulance patients were bad patients and were full of people coming in for pharmaceutical refills until we produced the data from all of you that says that that's not true at all. And then very importantly, it's our opportunity to identify best practices and to share those best practices. I brought one more piece, and this piece is so new it is not in your handout, and I apologize. Last week came a subtle study that talked about charges for services. And I put a lot more in here, so if any of you want a copy of this, you can get this from me. I'm happy to share this, but there's another CMS initiative through the HRQ to look at medical expenditures. And last week, they put together a format that allows us to look at emergency department charges and payments, all right? And we have not had access to this kind of data before. In a study that is not yet published but is coming out, they looked at data from 2005 to 2010 and found that for Medicaid uninsured, privately insured, and Medicare patients, average charges, and for the first time this is all in, this is facility, ancillary testing, and physician charges, and then the payments made. And they did this by sampling the insurance policies of individual patients, all right? So pretty clean methodology for doing this. Very large numbers. Average charges, if you'll just run the numbers there, probably $2,200 to $2,300 in the years 2005 through 2010. Average payments highest for Medicare patients, lowest for uninsured patients, nothing unexpected there. And that leads you to think through other sets of data. I live in Naples, Florida. In Naples, Florida, we have the nice hospitals there, and at some point I would like to know what the charges are if I'm going to go visit the emergency department in Naples, Florida. Well, the Florida Agency for Healthcare Administration has queried all of the hospitals in the state of Florida and asked them about their charges. This data has been updated in 2008 numbers, and lo and behold, the average charge if you're an adult to visit the emergency department is almost $3,000. Anybody would have thought that number? $3,000. For a child, it's about $1,300. For low acuity visits, not much difference in terms of the numbers here. This reflects our charge master can't discriminate between low acuity and high acuity very well. And then some data based on presenting symptoms: abdominal pain, hypertension, asthma, headache, including migraine. They deemed about half of emergency department visits in the state of Florida as being avoidable. And they have an interactive model, so again, I can look at Naples, Florida, and decide if I'm a CMS beneficiary or anybody else, what is the likely to be the least charged facility that I can go visit for my emergency needs. They counted 7.1 million visits in Florida emergency departments for the 12 months leading up to June 2012, so this is updated. Their data run to that point produced an average charge of $3,500. It resulted in a total of $25 billion in charges for Florida patients going to visit emergency departments 12 months leading up to June 2012. If we said those numbers are the same across the country, just so you know, we get to use the word T, the word beginning with T, in our vocabulary. If we make an assumption that emergency department patients seen across the country, 140 million of them have average charges of $3,500. We now have $500 billion in charges for emergency care in the United States per year. Anybody want to dream to that? If we make a valid assumption based on the other data that there's about a 30% recovery rate, that's $150 billion to manage our industry, to pay our bills for emergency care across this country. ACEP has used the "we're less than 2%, don't leave us," or don't pay any attention to us. This just reflects the emergency department. We will talk later, and you know that you manage about 70% of inpatients that go upstairs. That adds $1 billion or $2 billion to the bill in terms of financial accountability that emergency department leaders are responsible for. We are a big industry, and we need to be very responsible. And the Time article that was published last week, took all of us in healthcare to task for how America manages the finances of the healthcare system. So I slipped that in there, and I apologize. That is information that came available last week, long after the books were published. Okay, 1994, we began a process of looking at the needs of emergency departments that were getting big and hard to manage. In 1994, a big emergency department was one defined as seeing over 110 patients a day. A really big ED was seeing 40,000 visits per year at the time. These days, a 40,000 visit ED is below the median, all right? We produce data cohorts, and the data cohorts and the reports that you all get have broken EDs into what are still management-challenged volumes. They change at the 20,000 volume mark. So we cohort our emergency department 0 to 20,000, 20 to 40, 40 to 60, 60 to 80, 80 to 100. And in the last couple years, we've had enough emergency departments, we had to create the super center size statistics, which are over 100,000 visit emergency departments. And then we take the data from each of those, plot them here, and give you the results cohort specific. In addition, in the last 2 years, we've gotten enough emergency departments that see a predominance or only children that we are able to define a pediatric emergency department group. And the last line we have also created in the last 2 years, enough of you are now running standalone, freestanding, and urgent care centers as part of your emergency department. We now have a data line for that group of facilities. What you'll see in the slides here are box and whisker diagrams. And the box and whiskers are a really nice statistical way to show you how wide the variation is within certain bands. And by looking at the median numbers and then the spread of numbers, you have the opportunity to very precisely look, draw a red line in where your emergency department is, and then use these as a report or a placemat to discuss operations in your emergency department with your administration. The box and whisker diagrams are going to be the way that we represent a lot of our data that's going to come back to the Benchmarking Alliance over the years. And this does the introduction to that. For example, this set of data here is about the percentage of patients admitted to the hospital, admitted to either admit status or observation status after being seen in the ED. The way that this data is presented, the left-hand column is for the entire cohort of emergency departments. This was 840 EDs. And then we splice them up, beginning with the super centers, over 100,000, 80 to 100, and so on. And then the last two columns, adult emergency departments and pediatric emergency departments. So you can draw your blue and red lines, break up the data as you need to, and understand how your data at your facility interacts with the data for your peers. Another important data point for you is those patients who leave at any point before they're supposed to. And a very important definition for us is everybody who leaves before they were supposed to leave. And that leave before includes any definition you want to put in. Eloped, AMA, before screening, after triage, before triage but after screening. Whatever it is, they all have to be lumped in here together because there's no statistic that in the ED we cheat on more than this one. All right? And so we said lump them all together so that somebody isn't reporting data that's completely out of line. As you will notice here, larger, high-volume EDs have a more difficult time getting people to sit and stay. In small-volume EDs, in general, you can get them in, plugged in, and they stay. Adults leave more than pediatrics. And the overall trend in this, thank goodness, is heading down. We're doing a better job of getting people into our emergency departments and having them stay. You have on your slides in front of you another series of these box and whiskers. I'm not going to describe them all in detail, but you now have a baseline for what those look like. And I'm going to move ahead to what are the rest of the data, how it applies to you, and how you're going to take opportunities to strategize and manage this. All right, this is a diagram that all of you should copy and put in your numbers. Okay? The CDC says for a given population in a region, about 450 visits occur to the emergency department per year for that population set. 450 visits per 1,000 is our number. About 80 of those come by EMS. About 371 of those will walk in. We manage them in the ED, and then they get dispoed. 2% get transferred, 17% get admitted, 81% get treated and released, about 2% leave before treatment complete. So those are our big numbers. But what you do with this diagram is you scratch out the numbers and you put in your numbers so that it reflects your market. NAHAMSA says that 3% per year is our average growth rate across the country. It says our injury load is decreasing. It's now at about a third. When I started in emergency care a long time ago, it used to be 50% injuries, 50% illnesses in our ED. We are now sequentially shrinking the number of people who arrive, who many of us like to manage. We like taking care of sprained ankles and lacerations and other things, and therefore the population is moving away from that. And you know, the chart rack at home in your emergency department now at this time of the day probably says chest pain, short of breath, abdominal pain, weak and dizzy, headache. Repeat the sequence. And somebody is finding gold now, which is a chart that says ring stuck on the finger or sprained ankle or something, and they're grabbing that chart eagerly, saying, "Man, this is a definitive one I can do something about right away." All right, and the person who's picking out the chart that says weak and dizzy, and the next one that says weak and dizzy is thinking, "Oh no, it's going to be another day." Okay, injury rates not highest amongst the young people. Highest amongst the age group over 75. And those people are all on what class of medicines? They're all on thinners. And somebody at home right now is making the decision about do I scan them and when do I scan them for their head bonk on thinners, and do I do this or not, and can I justify admission so that they can be scanned again or obsed in 23 or 48 hours, whatever it may be. The most frequent visitors to our emergency departments are people who live in extended care facilities. And they have about a 45% admission rate, and they account for about 2.8 million visits. Predicting volume ahead. If your community is like most American communities, they're getting older in your community, and as they get older, they come to visit the emergency department more frequently. As we build more people into this population base, and this is again a NAHAMSIS opportunity, they have all the population and census data and can look at utilization of emergency department based on age groupings. As we push more people into over 65, over 75, and over 85 age groups, those people will statistically use the emergency department much more frequently. This is our, and those of you who've seen me talk before, this is my 30-year career in emergency care, which is we grew up pumping on people's chests, taking 16-year-olds out of cars wrapped around trees. I enjoyed doing that all of my EMS career, and now we see it very, very rarely. It's a success story. All of American healthcare is about the success of us preventing premature death and letting people live more comfortable lives into a much older age. We didn't think ahead, and our big insurance company, the federal government, didn't plan ahead to say, you know, if we don't have people dying early, they get old. They get hypertension, they get cancer, they get diabetes, they get some complicated diseases, they get multiple system diseases, and it is a success story and not a failure story. What we should have known is that when prevention works, people stay alive to get ill. It costs more in things like our trauma population age. And in my community, taking people that are wrapped around trees out now are typically 80-year-olds who probably were unconscious as they went up on the sidewalk and hit the tree, okay? The next piece for your staff, your population changes, and in most communities this goes injuries shrink, mental health visits increase to the emergency department. They have no place else to go. In your community, mental health agencies often know that EMTALA requires you to see patients in your emergency department. And they know that if they don't want to see them, they can send them to the ED, they can demand that tests be done on them, and that if their K is 3.4, they have a reason to say that person's too unstable for me to take and transfer to whatever my facility is. Is there anyone who hasn't had that experience yet? They can tell you that they won't accept the patient until what test is done? Drug screen. Got to have a drug screen. And your staff gets to fight with them, and then they get a result that's THC positive. And you get to tell the staffer there that has nothing to do with their current presentation. They're suicidal, threatening to kill themselves, and that they were acting even worse when they came in, and that result does not exclude them from being admitted into their service, wherever that happens to be. Our payer mix really hasn't changed very much, and despite the economics of the country, the percentage of Medicaid self-pay has not changed significantly. What has changed significantly is the increasing percentage of patients covered by Medicare. The utilization, just so you know by the numbers, number one users of EDs are nursing home patients, the homeless, and infants under age 1. We have a very different population of patients seen in pediatric and adult emergency departments, and it is only fair for those of you who understand how your ED runs, that if you have a high mix of pediatrics, you see a very different population than an ED that sees a very low mix of pediatrics. Therefore, we do comparative statistics that look at adult and pediatric patient populations and understand that CTs and EKGs and a high number of x-rays are not done on pediatric patients. Admission rates much higher in adult patients, acuity much higher, EMS arrivals much higher, and any of the other markers that you want to use. So one of the important differentiators of EDs is what is their pediatric mix. Okay, flipping back to NEHAMSIS for a second, I want to tell you that our market has changed by their data since 1992. Each of these bar graphs, I could take 1992 and 2010 and show you the increases or the decreases. Instead, I have taken the 16 intervening ones out, and I'm just showing you 1992 versus 2010. And these are absolute numbers. Absolute numbers of cardiac enzymes that were done in 1992 are the left-hand set of bars. In 1992, we did about 2 million studies on cardiac enzymes in emergency department. Big surprise, in 2010, we did about 18 million sets of cardiac enzymes in emergency department. EKGs, similar trend. Biggest differences in use of CT scans, where dramatic increases have occurred. X-rays haven't gone up so much, and in many cases, X-rays are replaced by CT scans. And in many of your emergency departments that I've trended you over the years, your number of X-ray procedures per 100 patients seen has trended down. Therapeutics. This looks at wound care, ENT care, orthopedic care, and IV therapy. Okay? Really, our wound care hasn't increased at all, and many patients who need stitches in your community may choose to go to the emergency department, but I also may choose to go to Minute Clinic or urgent care or something else. We also have prevention that has prevented a lot of wounds. And the CDC's report on pediatric head injuries is one of the, again, very, very, very encouraging elements of what we have done in this country in prevention. They marked a 75% decrease in pediatric head injuries seen in EDs. Thanks to what simple tool? Bicycle helmets. Okay? Bicycle helmets that have reduced tremendously the number of kids and kids with devastating head injuries that we have seen in emergency departments. Why does ENT care go up? Because we see elderly patients on thinners in the winter months who come in with their noses bleeding, all right? Which leads me to one of our other very dangerous elements of data, which is revisit and readmission. One of your emergency departments is busy enough that this month, you saw this many patients in your ED with nosebleeds. Probably most of them were over age 65 and were on thinners, all right? Your staff faced all of these people and said, you have a nosebleed. Here, I'm your doctor, I'm your nurse, I'm here to take care of you. If we beat your staff up and say revisits are bad, and you guys are bad providers if you don't take care of these nosebleed patients and prevent readmissions and revisits to the ED, what is your staff going to do when they approach each one of you with your nose bleeding. They're going to say, I'm going to cauterize, I'm going to pack, etc. If I'm bad, I'm sorry, ma'am, you're going to need to be admitted to the hospital. We're going to put you in OBS. We're going to put you upstairs, feed you hospital food. Is the environment of a hospital good for people with dried mucous membranes? Anybody want to guess what humidities are inside of hospitals? Pretty darn low. And I'm sorry, ma'am, you're going to stay here. If I believe I'm going to be dinged for revisits and readmissions, many more of you are going to be staying in the hospital. For many years, we have all practiced nosebleed care, talking to all of these people with nosebleed, saying, ma'am, there's a 5% chance that you will rebleed, despite the really good job I have done cauterizing or packing your nose. Would you prefer to stay here in the hospital, or would you prefer to go home? You'd prefer to go home, eat your own food, sleep in your own bed, have a humidifier in your room, and I'm going to give you instructions that allow you to most safely care for your nosebleed. Ma'am, there's a 1 in 20 chance that you're going to return to our emergency department. That's not a failure on your part. That's not a failure on my part. But I believe you'll be much more comfortable, and there's a 95% chance of success. I believe that's good medical care. And I reject the idea that readmissions and revisits in and of themselves are bad. And oh, by the way, many of you are using revisits as a way to provide excellent emergency care. For many of the MRSA, head bumps, everything else that we deal with that you'd like to recheck. Statistically, it's very hard to take planned revisits away from unplanned revisits. And therefore, this revisit rate around emergency departments, and extend that upstairs to the orthopedic surgeon who does a knee replacement, and send somebody home at 3 days because they're into rehab, they're doing well, their thinners are working, their pain's under control, and they talk to that knee replacement patient and say, there's a 3% chance that you'll have a problem. 97% chance that you'll do better at home, be more comfortable, get your rehab and your pain control, and et cetera there. Or if I'm going to be a bad orthopedic surgeon for sending you home, we're going to keep you for another 2 or 3 days to make sure that we reduce that risk even further. Everybody get the idea? Revisits, readmissions, not, in my opinion, in and of itself, a statistic that reflects bad quality care. And we are going to put our people in a bad way, particularly related to groups of patients like this, that we otherwise have been very comfortable managing and accepting a very low failure rate for whatever reason. Ortho care not up much, IV therapy is up much. For those of you who like to do critical care, you're 30 years too late, okay? We don't pump on people's chests, we don't intubate nearly as frequently as we used to. These numbers have fallen precipitously. What has also decreased are death on arrivals, and those patients we don't see as frequently, and we make better use of hospice and palliative care than we used to 30 years ago. Mental health visits, look at this, 92. We used to see very little self-inflicted wounds. We now see a lot of self-inflicted wounds. That is a particular wound, that is a particular categorization of the HAMSIS. Mental health admissions to our own facilities and mental health transfers in particular have gone up dramatically. All right, back to benchmarking alliance data. So this is the breakout of all of the data. Supercenters, seeing over 100,000, and forgive my use of that nomenclature, but really you are the supercenters of emergency care, seeing over 300 patients a day. That's a big place. We then have the various cohorts down through the very smallest emergency departments, and then again what I will call pediatric emergency departments or care facilities. We have the freestanding urgent cares and standalones. The survey for 2012, 1,000 EDs will present data to us that'll have 35 to 40 million patients. I believe our volume will be up 2012 versus 2011. So far, acuities continue to increase, and more patients globally are admitted. We continue to increase EKG utilization, and for those of you, another big story is people won't read the textbooks anymore and know that they're supposed to present with chest pain when they're having an acute MI. They present with anything but chest pain, and you have to use your tool, the EKG machine, to evaluate many patients who in prior years we would not have considered at risk for ACS. And so weak and dizzies, I don't feel wells, I'm just sick, get EKGs done now. And it is much more frequent, frankly, that they present with ST elevation than the patients who present with chest pain. We will continue to see a plateau in usage of CT scans, but what is bumping up now is the use of MRIs. And 10 years ago, if you'd have said we would be doing MRIs out of the emergency department, I would have said, that's crazy. We can't do that. And now we have one of the first EDs that reported this year is using MRIs 5 per 100 patients seen. 5 per 100. EDs are continuing to improve throughput. Walkaway rates continue to decrease. 18% arrive on an ambulance gurney and are admitted at an increasing rate. Payer mix is stable except more Medicare. For those of you designing emergency departments, the old adage of 2,000 visits per bed is dead. It is dead. It is not the right number. Don't let them build your ED at one bed per 2,000 patients. CPOE usage is up dramatically. And noted for 2011 is that 75% of you are using computerized physician order entry. That is a dramatic increase in 2 years and has something to do with meaningful use and dollars coming from the federal government. And new team triage systems now measure over 25% of emergency departments surveyed. Back to the data, and we'll go through some of this. The EDs that are seen have this representation in terms of urban, suburban, or rural. Larger EDs have a tendency to be academic in nature, teaching facilities more frequently than small EDs, and a trauma designation is present in about 94% of the very large emergency departments, much less frequently in small EDs. Fast track areas are present in the predominance of emergency departments seeing over 80,000 per year. A trauma area is physically present in over 80% of emergency departments, over 80,000 visits. We're seeing an increase in use of CDUs and OBS, and as a design suggestion for all of you, CDUs are a very good way to manage patients over a longer period of care and to reduce readmissions and revisits. And I think they're going to become a very important tool in the next 2 years as the federal government focuses hard on readmission rates. Computerized physician order entry, and by size, you see the numbers here, but overall, there are very few EDs being left in the dust in terms of implementing computerized physician order entry. Does anyone want to volunteer that this has made their ED more efficient? Does anyone want to volunteer that their staff are able to be more productive when CPOE is implemented? We have a problem. We looked at greeting, and about, everybody but a few of those under 20,000 use nurse greeting processes, and I believe we should change the name systemically and not use the term triage anymore. Greeting areas. Present with nursing in almost 100% of EDs surveyed, but you see overall EDs, about 18% now using physicians and about 8% using mid-level providers at some point in their greeting process. I will talk specifically about that later this morning, correct? Scheduled hours. This is the inverse of the ENA numbers, but we asked you to report on your scheduled hours for nurses, techs, clerks, physicians, and mid-levels. Scheduled hours. We took the volume that you see, patients per day, and divided it by the number of scheduled hours. Many of you are familiar with this on the physician side, and we come up with the patients per physician per hour. On the nursing side, here's the data reflected in the left-hand column, and we see great consistency amongst nursing utilization per patient. Across physicians, this is a number that's a little higher than usually what gets posted, but it is because we use the term scheduled and not actual worked hours per day. And all of you know that physicians have a tendency to stay over at the end of their shift or come in early if it's busy. But the numbers are running between 2.6 and 2.9 patients per doc per hour. unless you're in a very small ED. In a very small ED, they statistically can't get to 2 patients per doc per hour because they don't see enough patients to be able to see that number. And then when we add in mid-level providers, we get down to the number that usually gets published about physician productivity, which is 2.2, 2.3 patients per provider per hour. High acuity visits going up most dramatically in EDs that see over 40,000. And just looking at a trend here and finding some interest in this, EDs that see under 40,000 are not seeing the same level of acuity increase. And it may be that in communities that have busier emergency departments and not busier, that the specialists and specialty services are coming available in the shops that have more specialty services available, and the sicker patients are moving towards those higher volume shops. Worth everybody noting that it's getting most difficult in the bigger volume emergency departments managing higher acuity patients. Length of stay and walkaway, this is a trend line, with the left-hand bar being 2005, the right-hand bar being 2011. And what we have noted is that our length of stay was increasing, and it got over 3 hours. Accompanying that, statistically, in a perfect correlation, we were watching more people walk away. As many of our hospitals, and a key person for you to listen to, Suzanne Stone-Griffith, when she talks later today, she led an initiative in her HCA hospitals that reduced processing times, reduced door-to-doc, and dramatically decreased walkaway rates in 160 HCA emergency departments. Her success in doing that, and your success in the remainder of the emergency departments in the country, we have trended in the right direction. We're probably going to take a bump back this year because of flu, and our processing times for the first couple months are up, and our walkaway rates are going to be up. This is a scatter graph of length of stay and left before treatment complete, and you see there would be a correlation here that if you let people linger in your emergency departments, and statistically we've shown that this is admitted patients. Leaving patients longer in the ED results in more beds being stuffed on evening hours and people walking away at a higher rate. So it matches what inherently we would think about our emergency department patient behavior. Admission times, very large emergency departments, very busy EDs, have a harder time getting admitted patients going upstairs. In a small sampling of data from 2011, this is what you reported because many hospitals were not collecting this yet. Boarding times highest in the very large EDs, going down to the small and micro emergency departments, higher in adult than pediatric serving emergency departments. EMS still bringing us patients. That's about 26 million a year to American EDs. 42% of them are admitted. Correlating, if you want to increase your admission rate, invite the ambulances to come to your door. Statistically, these have trended for many, many years across all size emergency departments. Our important trends, even over 8 years of data from the Benchmarking Alliance, EKG utilization has gone from 17 uses to 26 uses per 100 patients seen, 17 to 26 uses per 100 patients. And the inpatients arriving upstairs, 58% of those in 2004 came through the emergency department. We're at 67% in 2011. And for those of you who have no labor and delivery unit, typically you're admitting 85 to 90% of the patients who are arriving in inpatient beds. EKG increasing significantly, and again in all size emergency departments. And there's that percentage admission that has increased steadily and dramatically. When I first started, about a third of admissions came through the ED in the late 70s and early 80s, and now we're at 70% almost. Here's your square footage and patients per bed relevant to your cohorts. There's really not much variation by volume of the emergency department. And again, every CEO and COO in this country somewhere was taught that it's 1 bed per 2,000 visits, and that number is not relevant anymore. All right, putting data to work in your ED, I want to let you know that this is a per day statistic that you can give to staff and have them manage up to it. So I took a day in our emergency department, Cincinnati, Ohio. 130 patient day is our average. It's worse on Sundays and Mondays. 3 patients per day want to walk away. It's our job to keep them there. 40 go to the fast track. 56 need to be put on monitors. 23 are going to be admitted. So Mr. Tech, 25 patients per day, worse on Sunday and Monday, are going to need to be pushed upstairs. To the admitting officer for our hospital, on average, 25 beds need to be available today to be bringing patients upstairs. It's worse on Sunday and Monday. Will you please have beds available for us? An important number I continue to share with you, it is 8 orders entered per patient seen. So the docs have to be tied to their computers where we're doing CPOE. They have to be ready to put in 8 orders per patient. This is our Epic system. We had no idea what the numbers were in the past, and because the whole house has Epic systems, we recognize that 21% of all orders put in to the hospital today come through the emergency department, and so on. Go home, think about your numbers, print them up, do them per day, understand them, be able to compare them to cohorts, be able to tell a story to your administration and to your staff that is relevant to how you run your place. For any of you who want further numbers and want the discussion, I'll be available for the next 2 days. Thank you for the opportunity to present, and I'll be available for questions in the back as we move to our keynote speaker. Thank you.